The TMJ TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ TMD Demystified podcast.
Good day to all of you TMD warriors. I am Tony Urbanic, and this is TMD Demystified. Today we're going to talk about TMD/TMJ as a disruptor versus the status quo. What I have learned in 50 years, literally 50 years of work and treatment and investigation on TMD turns out to be quite simple and turns out to be quite disruptive to the status quo. That is a big statement, but can be proven. As I have stated on other episodes, I do a parallel blog of the same topic, of the same title every week. And my blog this week was entitled TMD TMJ Disruptor versus Status Quo. I assume you all know status quo is basically the current state of affairs of any particular topic, and there is a status quo out there regarding TMD. And what I have found out is that the simple truth and knowledge of what creates the symptoms is a disruptive technology. The technology is not this device, and let's get that cleared up first. Very important to understand what I'm talking about. This device that fits in the roof of the mouth is a tool. It is a simple tool that fits in the roof of the mouth that carefully and adequately separates the posterior teeth according to a protocol, which allows the inflammation to decrease to the point where the symptoms go away. But the technology is not the device. The technology is the knowledge of how the symptoms are created. And that is what I discovered. That is what I put together. That was connecting the dots, literally, connecting the dots that already existed in the literature. Literally common knowledge that had been present for, 60 or 70 years, some of it, and putting it together to describe how chronic inflammation in the temporomandibular joint creates all of the disparate symptoms of TMD. And both patients and doctors I've observed have this confusion that the technology has something to do with this piece of resin that fits in the front of the teeth. Well, all that device does is separate the back teeth, and then a protocol is used, but you have to have a device that the person can speak with for sure. It has a unique design to it. It is patented, both in its acrylic form and in its resin form. It is patented both in the form that is made with acrylic and a ball clasp, and it's patent pending with its design using resin only and attachments on the premolars to separate both the premolars and the molars. But again, the disruptive technology is knowledge, not the device itself. I told the story many times, brings to mind the story many times about the patient who was not very happy when she learned how I literally stumbled in to the investigation and the proper place to look when I said, my patients told me if I put a pencil between my front teeth, it feels better. We made a device that did that, separated the back teeth, and had tremendous results. And she looked at me and she said, do you mean if I put a pencil between my front teeth, it'll make my symptoms go away? And I said, yes, ma'am, it'll make your symptoms go away. You just have to figure out how to hold a pencil between your front teeth for 2 months, 24/7, except when you eat. She did not like my answer, and she glared at me, but we won't go there. It was a turning point in my career. I never did that again. I never was honest with the patient again, that honest with the patient again. It's just, patients want it complicated. Doctors want it complicated. Patients who have this enigma, this conundrum that they've been trying to solve for decades that ruins their life with headaches, earaches, jaw pain, neck pain, etc. They want it to be complicated because it has to be complicated because nobody has known what to do. Well, tracing back the history, which I've done before in other episodes slightly, we're going to pull it all together today. There were major mistakes made that got us where we are into the status quo. Well, first of all, let's define status quo. Status quo means existing state of affairs in Latin. Doctors got to speak in Latin, right? Sound important. The existing state of affairs regarding TMD is that, first of all, both physicians and dentists, everyone knows nothing works really long-term. Nothing works long-term. 50% of the dentists don't want to hear anything about TMD. If they have a patient with the problem, if the patient says TMD, they close their ears. They just want them to get out of their office. They don't want to hear anything about it. And 50% of the dentists, or let's be accurate, 49.99% of the rest will open their ears and make a night guard for the patient and hope the patient doesn't come back after delivery of the night guard. And then there's the 1/100th of the profession that are called TMD gurus that throw things at the wall to see if they can stick. So what do they throw at the wall? They throw at the wall any series of services that basically boil down to trying to get rid of the symptoms. What could that be included in? That could be included in neuroleptic drugs, manipulations of muscles and teeth, dry needling, physical therapy, chiropractic, massage therapy, botulinum toxis, paralysis of the muscles, Botox, acupuncture, orthodontic treatments of various kinds, occlusal rehabilitation, psychologic and psychiatric treatment to try to diminish bruxism, which is crazy because we don't even know what causes, we don't know the mechanism for bruxism. We do know bruxism is related to stress, but everybody's stressed. I mean, truly. And then they give drugs for anxiety, and then the patient gets further on down, and all the side effects of drugs for anxiety. There's hundreds of those that are passed out. I see it all the time. And various kinds of surgery. That is the status quo. And I've participated in the various kinds of surgery for 36 years until I decided that I couldn't continue doing that because doing surgery for patients, 30 to 40% of the time, the patient would be back within 1 or 2 years with the same symptoms. So it wasn't ethical for me to tell a patient, and I knew that. I knew that 30 to 40% would be back within a year or two, or sometimes less, with the same symptoms. And I couldn't look at a patient and honestly say, I'm going to do this surgery for you and fix your problem, knowing that 30% of the time you'd be back within a year with the same symptoms. Couldn't do that anymore, at which point led me to the direction of further investigation on my own to see if I could figure out this conundrum called TMJ. So there were a series of mistakes that led us to the point where everyone knows nothing works. There's a series of doctors out there who I call gurus that throw things at the wall to see if they will work, primarily just trying to limit the symptoms temporarily, and everyone knows, including Botox, for whatever value it has, is just a temporary fix. You will be back in 3 or 4 months. And then, of course, there's the recent article in the Journal of Oral and Maxillofacial Surgery that literally, academically, statistically proves that injecting saline and Botox into the masseter muscle to paralyze it basically has the same effect. Saline versus Botox. So with that in mind, the status quo doesn't hold a lot of water. And the fact that there is a disruptive technology based on knowledge, not on the device, because if you can figure out how to hold the pencil between your front teeth and not direct the mandible anywhere and just allow it to go back to centric relation versus centric occlusion, and unload the joint adequately. In other words, take the forces off the joint which create the damage, just like a bad knee is generated by years and years of jogging, or an acute traumatic event like a motor vehicle accident and whiplash to the temporomandibular joint. Acute trauma leads to chronic inflammation. Chronic trauma of bruxism leads to chronic inflammation. Functional malocclusion of various kinds, minor or major, minor meaning small differences between CO and CR, or major differences, which would be attuned to orthognathic reconstruction. But functional malocclusions of both kinds can damage the joint, leading to chronic inflammation. And then chronic inflammation is now known to create each and every one of those symptoms. So the first mistake was to literally give by default the treatment of temporomandibular joint disorder, TMD, to the dental industry, which weren't prepared for it in the 1930s and 40s. They had no idea. And Dr. Costin, who originally identified and wrote on the problem and was known thereafter for the next several decades as Costin syndrome, he theorized that the cause of Costin syndrome, now known as TMD, was lack of posterior teeth. And from that point on, it was given to the dental profession to handle, because the original theory was there was a lack of posterior support, which created the symptoms, lack of posterior teeth. Well, it must be then in the hands of dentists who know how to, at that time, our only opportunity to fill in teeth were like partial dentures, or if it had a tooth behind it, maybe a bridge. So it must be a dental problem. And so it was given to the dental profession that frankly didn't know how to handle it, didn't know what to do about it. But it did filter into the dental schools. Well, and now it's a dental problem. And in the 30s and 40s and 50s, the dental schools had this thing called TMJ dumped in their lap. And the second big mistake is that they just called it TMJ and did not even consider the relationship of the basic sciences. It was a tooth problem. It was a lack of teeth. They didn't factor in any consideration about what the basic sciences had to say or not say about joints in general, and they just called it the name of the joint, TMJ. And for the next several decades until present time, that is exactly how it is considered. It is just called TMJ, which seems, we all know that, seems kind of funny, unique, absurd, because if you had chronic and constant knee pain, you wouldn't go into the orthopedic surgeon and say, I have knees. But that announces, it celebrates how confusing the enigma was, that there was not enough attention to even name it correctly. I'll just repeat that. That's a true statement. There wasn't even enough thought process into this, critical thought, critical investigation into the process until later into the 1970s and 80s when they finally realized that calling it TMJ didn't do justice to the problem itself. But still, in 2024, most of the patients I see and most of the physicians I talk to, and frankly, most of the dentists I talk to still refer to it as TMJ. But that was the second biggest mistake that was perpetrated now by the dental profession, who was given this problem to solve. There wasn't anybody else to solve it. It was by default given to dentists, dental schools, dental profession. Here it is. Here's your joint. And the third and largest and most profound mistake that was perpetrated on the public and perpetrated on young dentists who were being trained was every dental school to this date, which is, in this date actually is November the 12th, 2024. To this date, every dental school in the United States of America teaches young dentists to be that this joint is really unique. It is special. It is complicated. It is so complicated we haven't been able to figure it out. And certainly, since we haven't been able to figure it out, which are the elite academicians and academics in dentistry, certainly, young doctor, you're not going to figure it out. And that's the message all the dentists coming out of dental school come out with. And I have said this to hundreds of dentists, both young dentists, middle-aged dentists, and old dentists, and not one of those dentists disagrees with that statement. They all absolutely shake their head and agree. Yes, I was taught in dental school that this joint is different, unique, special, complicated. Complicated. It has a complicated name, but it isn't complicated. The truth is this joint operates like any other joint in the body. And starting out from that piece of knowledge, which is fact, this joint operates like every other joint in the body: the knee, the hip, the elbow, the pathophysiology, the histology, the biochemistry, how muscles work, how pain is distributed, where pain comes from. This joint operates like the knee, the hip, the elbow. And when you start out from that point of view, then it becomes obvious how chronic inflammation within this joint can create first all kinds of different facial pains, and then all kinds of different neck and upper back pain, and then all kinds of upper body and shoulder pain, including arm, hand, finger tingling and numbness, and including the symptoms associated with the middle ear, which are tinnitus, subjective hearing loss, and vertigo, all of them generated by chronic inflammation, which either type 1 generates pain or type 2 chronic inflammation within the middle ear through the petrotympanic fissure, through a fissure that goes from the glenoid fossa into the middle ear. Short fissure at that, but it is a fissure. The petrotympanic fissure, better known as lesser known as the Glaserian fissure, observed and named by Dr. Glasser, a Swiss anatomist, in 1680. That petrotympanic fissure has been there all along, identified in every issue of Gray's Anatomy, amazingly present, unidentified, undetected by the dental establishment, but it's simply been a matter of connecting the dots to explain how overuse, overloading a joint, hip, elbow, knee, temporomandibular joint, creates chronic inflammation, which then goes on to create bone destruction, certainly, but it's not the bone destruction that causes the symptoms. It's the chronic inflammation that causes the bone destruction. It is the chronic inflammation that generates the pain by signaling the central nervous system, brainstem, I'm inflamed. The brainstem says, oh my God, you're inflamed. I'm going to help you out. Don't move the joint, in this case, jaw joint. Tighten up the muscles that move the jaw joint at various times, at various muscles, not all the same muscles. And patients will complain of disparate symptoms on different parts of their face where the muscles attach to the bone, which stimulates the nociceptors in the periosteum, which create the pain. And this goes on first to the muscles of mastication, then the muscles supporting the head, which are the neck muscles, the scalene muscles, the strap muscles, the sternocleidomastoid, the trapezius. So that explains both the symptoms of the middle ear and the symptoms of pain generation of the head, the neck, and the shoulders, going all the way into the arm when the brachial plexus is squeezed by the strap muscles. Squeeze the brachial plexus, it's going to give you symptoms in your arm. And that same mechanism is the same mechanism that gives you knee pain, same mechanism that gives you elbow pain. That is why tennis elbow and TMD actually are the same disease. The mechanism is the same between and among patients who have tennis elbow and TMD. Same mechanism. Orthopedic surgeons have known about this. Well, since I was trained in my orthopedic rotation at Vanderbilt, that's where I learned about joint splinting. Joint splinting described by orthopedic surgeons as it applies to the tennis elbow. Lateral epicondyle becomes inflamed from too much tennis, sends a signal to the brainstem, I'm inflamed. Brainstem says, don't move your elbow, tighten up what? The muscles of the forearm. And tennis elbow is pain in the forearm into the wrist by the muscles that are attached to the bone and stimulate the bone at the periosteum, the nociceptors. Same thing. Now, is this complicated? No. Has this bit of knowledge been present in the literature and knowledge by others for a long time, like 70 years? Yes. So the status quo is invalid. The status quo, by throwing things at the wall just to placate the symptoms for a short period of time, is not the right thing to do. It's not the correct thing to do. Frankly, if you know the difference, it's not the ethical thing to do. You may make a lot of money doing Botox, but frankly, it's not ethical. And I stick by it. I made the statement before. Knowing this and knowing the recent article in the Journal of Oral and Maxillofacial Surgery, Botox is a scam. But it's out there, and it's being perpetrated on patients and encouraged by the millions of dollars spent on advertising by the various companies that manufacture botulinum toxin A, always getting the patient to come back in 3 to 4 months to paralyze whatever particular muscle of the day, muscle du jour that hurts, ignoring all the other muscles and ignoring, which frequently ignore the symptoms of the middle ear, ringing, fullness, dizziness, which certainly can't be handled by Botox. And that's just one example of all of these symptoms that are used as the status quo treatment of TMD. Neuroleptic drugs, manipulations of the muscles and teeth, dry needling, physical therapy, chiropractic, massage therapy, botulinum toxins, paralysis of muscles, acupuncture, orthodontics, occlusal, total occlusal reconstruction, psychologic and psychiatric treatment, including multiple kinds of drugs and various kinds of surgery. And of course, a disruptive technology, again, the technology is not this device. The technology is the knowledge of actually what is going on with TMD. That is the disruptor. The disruptor is that. And the status quo does not like the disruptor. But with enough persistence, with enough volume, and the advantage of having now the internet and having a voice, not a loud voice, not a broad voice, but it is getting broader. As we see in other areas of life, the internet as a disruptor itself and freedom of speech has allowed individuals with, let's just say, unique knowledge to get the word out there and let the public, whether it be professional public or citizen public, decide for themselves what makes sense, what's the truth versus what isn't the truth, what's nonsense, and what isn't in the best interest of individuals, the best interest in medicine, the best interest in dentistry, the best interest in the public. But that is currently in progress. And so the status quo, both in dental schools and throughout the dental practices in the United States and beyond, need to take a critical look at the status quo versus a disruptive technology and begin to change their point of view about the fact that nobody knows anything about TMD. There is no solution for the problem. To continue to close their ears or to make a device, i.e. night guard, that pretty much everyone knows doesn't work. There are still doctors that they were taught in dental school to use it and they still think it works, but they don't follow patients long enough to find out it doesn't work. And it takes a little time to round this corner and to make a change. With that in mind, with that said, if you, the listener, if you continued on to this point, if you would like to learn more about the disruptive technology that is available using this device, which is university tested and validated, FDA cleared, patented, called, unfortunately, we had to call it the Urbanic device. I couldn't call it the miracle device, couldn't do that, wouldn't do that. So my patients wanted to call it. If you'd like to learn more, you can get tremendous amount of information from the website, www.urbanictmj.com. You can communicate with me at any time. I would look forward to your communication via my email address, tony@tmjservices.net, tony@tmjservices.net. If you'd like to join our network, that can be done via the internet, or you can call me. I can get you involved pretty easily. I'll be happy to explain or answer any questions or criticisms. If you'd like to criticize anything that I have to say, I will be happy to discuss your criticism in detail if you wish. No problem. But I do look forward to any communication with you, and I encourage you to critically look at what I teach, what I bring to your attention, because we know that this problem called TMD is a huge problem. 45% of females have temporomandibular joint symptoms. We constantly see patients in our practice and affiliated network practices of patients who have had this problem for 20 years, 30 years. Yesterday, my day to see patients Monday, I saw a patient who had all of those symptoms checked off that I mentioned, all of those symptoms that went all the way back to 15 years old, which was she had the symptoms for 50 years and eventually picked up each and every one of those symptoms that I ran through. And I know that using the protocol and using that device, all of those symptoms are going to diminish for her. So that's the current situation. I look forward to the next time I'll pick a topic. I will pick a topic to further discuss and enlighten you on not only the technology itself. Again, technology is knowledge. Technology is knowledge, not just the device. And that will further the progression of this solution for TMD throughout the United States and beyond. I am Tony Urbanek, and this is TMD Demystified.